$800 for a Q-tip? Flu madness, med mistakes, concussion confusion, all of that and more in my first episode of This Week in the ER. My name is Dr. Eli Freiman, and I'm a pediatric emergency doctor. That means I see children in the emergency room. I see well over 3,000 patients a year, and in this video, I'm gonna break down some of the stories from my past week at work. If you've ever wanted a behind-the-scenes look into working as a doctor in the emergency room or getting into my head, well, here you go. Let's dive in. First things first, infection update. We are still seeing a ton of flu in the emergency room, and these symptoms are bad. We're seeing children with high fevers, 103, 104, 105, headache, which actually is more of an indicator in my world for flu than other colds. For whatever reason, I don't claim to understand all of it. Sore throat, congestion, runny nose, cough, maybe chest pain, belly pain, vomiting, muscle aches, the whole kit and caboodle. So much flu. And what's really frustrating about it, now we're seeing the strain called influenza B, but a couple months ago, we were seeing flu A or influenza A, which means that we're seeing patients back in the emergency room a couple months later when they were just there in January with flu A, and it's driving parents insane. No one likes to go to the emergency room at all. Imagine having to go to the ER twice in a couple months because your kid got the flu multiple times. It's brutal out there. According to the CDC, it's the worst flu season in 15 years. Flu was literally off the charts. Stay safe out there. I hope you got your flu shot. Thankfully, it looks like the numbers are starting to come down. So I'm hopeful as we get through the end of April, we'll start to get a little bit of a reprieve because it has been brutal out there. Now, I wish that flu was the only virus that we're seeing, but we're also seeing this pesky virus called rhino enterovirus, which technically is two different viruses that just get reported on our viral testing as one test result. The issue with rhinovirus in particular, if that's the one that children end up having, is that it's a really common trigger for asthma attacks. So when we see spikes of rhinovirus in the emergency room, we often see kids come in with really bad asthma attacks. It starts maybe as some mild cold symptoms, cough, congestion, runny nose, maybe low-grade fever, if anything at all. And then over time, they just start to get this tight breathing, short of breath, and they come into the emergency room with a full-blown asthma attack. Wheezing, labored breathing, the whole 9 yards. And these kids, even if they've been using their inhaler at home, it probably wasn't working, and they need back-to-back breathing treatments in the emergency room. They need steroids, sometimes x-rays, extra oxygen for breathing. I mean, gosh, sometimes we've even used IV medicines like magnesium, IV fluids, in order to get them to a spot where they're safe to go home. Unfortunately, many of these kids have been admitted to the hospital. So if you or somebody you know has asthma out there, be careful of this virus going around. It's been bad. I saw a 2-year-old come in just the other day with this exact story. History of asthma, frequent wheezing, uses inhalers at home, and had some mild cold symptoms over the weekend, but then over a 24-hour period, you could tell the kid started getting low energy, stopped eating, and then that breathing happened, right? Where the kid was breathing more than once a second. You started seeing those ribs going in, which we call retractions, and the parents knew it was time to go to the ER. I think that kid ended up being in the emergency room for 6 to 8 hours as they got breathing treatment after breathing treatment after breathing treatment, steroids, x-rays, and we finally got them to the point where they were safe to go home. But it was a little touch and go for a while. Honestly, I was a little worried we were gonna have to admit them to the hospital. And while it's now been more than 5 years, gosh, has it really been that long? We are still seeing a smattering of COVID-19. The good news about COVID-19 and whatever strain we currently have going around, it just seems very mild. If I had to rank the viruses in the emergency room that I see and how much they worry me, flu would definitely be near the top. There are some other scary viruses like adenovirus, human metapneumovirus, but flu is definitely up there. Second, I would probably put this rhino enterovirus. It causes the asthma attacks. It can cause vomiting, diarrhea. It's really not that pleasant. But actually at the bottom now is this strain of COVID-19. I don't know what makes this strain in children less virulent or just less dangerous in general than some of the other strains that we've been seeing. but I've admitted 0 children to the hospital with this strain of COVID-19. It always distresses parents to bring their child into the emergency room and have their baby. I saw this just 3 days ago, a 2-week-old who had mild cold symptoms, thankfully no fever, and ended up being diagnosed with COVID-19. I think they had an aunt who visited who came who ended up being sick. And the parents were freaked out because nobody likes to hear that their baby has COVID. And yet this baby looked so good. All we had to do was monitor the baby for a couple hours in the emergency room and they went home. So there you go, infectious update. Still seeing a lot of flu, the smattering of rhino enterovirus, asthma attacks, GI distress, vomiting, and then this COVID-19 strain, which thankfully doesn't seem to be that virulent. I'll tell you what I'm thankful for. We are no longer seeing this huge spike in norovirus that I was seeing in my ER just a couple weeks ago. Not a big fan of the norovirus in the ER. Healthcare providers will tell you that every healthcare provider gets one bodily fluid that they really don't like dealing with. Some people it is blood, even if they work in healthcare. Some people it's snot, some people it's urine. For me, it's vomiting. Even as a father of 3, I just really don't like dealing with the vomiting. And during neuro season, it's a really rough couple of weeks for me in the ER. So really glad that we're out of norovirus season, at least in my ER, but we are still seeing a ton of flu, rhinovirus, and that smattering of COVID. And that brings me to the medicine mistakes that I've been seeing in the emergency room. You'd think with so much flu going around and rhinovirus and COVID that parents would be pretty quick to pull the trigger in giving their kids Tylenol or Motrin at home if they're feeling ill. And yet every week I see parents bring their children into the emergency room before they've given Tylenol or Motrin. 3-4 days ago, I saw a 6-year-old with classic flu-like symptoms: fever, headache, sore throat, muscle aches, poor appetite, everything. You could have diagnosed flu from the door just from hearing the story alone. And the child had a fever up to about 103. And their parents hadn't given Tylenol or Motrin and decided to bring their kid into the ER. And it ends up being a really frustrating visit for everyone involved because they end up sitting in the waiting room for 3 to 4 hours with this kid with the flu. Because if you're familiar with emergency room triage, you'll know that the sicker you are, the quicker you get brought back. So if you come into the emergency room with flu-like symptoms and your vital signs look okay, you're probably sitting in the waiting room for a couple hours before you're seen by a doctor. So this kid was in the waiting room for a couple hours, was brought back finally to see us, and I told the family all the kid needed was some Tylenol. And ended up getting some Tylenol, felt better, the fever went away, and then they went home. And that's frustrating for the parents because they feel like they waited 3 to 4 hours for their kid to get Tylenol, which they did. And frankly, emergency rooms can be pretty expensive with copays in the United States. So it really does kind of feel like a waste of time or money for these parents. And I get that. That's not the experience I want patients or families to have in the emergency room. But there are a couple of things that that family could have done first before bringing in their kid. The first is you could always give Tylenol or Motrin at home. Unless your kid has a specific medical disorder or an allergy where they can't get those medicines, or if the kid's less than 3 months old for sure, it's always a good idea to give a kid Tylenol or Motrin, see if you can bring that fever down. The second thing the family could have done is give their pediatrician a call, because most pediatricians' offices have a nurse triage line or a way to get in touch with a medical provider, because that triage line could have told those parents, hey, give the kid some Tylenol, put them in a lukewarm bath, give them a popsicle or something to drink, and then see how they're feeling in an hour. It probably could have saved that family that ER visit. It's an everyday thing for me where I see patients come into the emergency room with fevers or headaches or muscle aches, but they didn't take any medicine before coming into the emergency room. And what ultimately happens is they wait in the waiting room for long periods of time only to be told, gosh, hey, you should have taken some Advil. And it's a really frustrating visit for the patients, also a really frustrating visit for me because that's not the experience I want anybody to have. Speaking of bad experiences that you really don't want anyone to have, about 2 days ago, I saw a 17-year-old soccer player who was referred into the emergency department for a concussion evaluation. This is something we see all the time. This kid was a 17-year-old soccer player who was playing soccer when he went up for a header and collided with an opposing player head to head. He fell to the ground, but didn't pass out. He was able to stand up on the field and walk off to the sidelines. Thankfully, he was evaluated by his team trainer immediately, and the team trainer noted typical concussion symptoms. The kid had a headache, he had started to feel dizzy, he had sensitivity to light and sound, he started to feel nauseated. and even threw up once on the sidelines. The team trainer diagnosed a concussion in this kid. Now, to the team trainer's credit, anytime there's a head injury or a concussion with any questions, it's a good idea to have them be seen by a medical provider. They referred the patient into an urgent care center, which seemed appropriate. So this kid went from the soccer field to the urgent care center, and at the urgent care center, the medical provider there said, yes, you have a concussion. You have all the classic symptoms. So now that was 2 medical providers who had diagnosed this kid with a concussion. But the medical provider at the urgent care setting said, you should go into the emergency room for a concussion evaluation. And what's frustrating about that is that this 17-year-old who had already been diagnosed with a concussion twice by 2 medical providers within the space of an hour was then referred into my ER. They sat in the waiting room for 3 to 4 hours because while they did have some symptoms, there were sicker patients who needed to be seen first. And eventually when they were brought back to see me, sort of like the patient with the flu who I told them, yeah, you just need to take some Tylenol, this kid I evaluated and said, yeah, you have a concussion. And it was a bit of a frustrating experience for him because he asked me, well, then why am I here? I was told that already by 2 different people. Why did they send me into the ER? Now, the emergency room is the appropriate place for anyone with a significant head injury if you're concerned about skull fracture, brain bleed, neck injury, or any other trauma that would require an emergency evaluation. Of course. However, this young man didn't have any of those symptoms. He had a classic concussion. He didn't pass out at the scene. He was walking on his own. He hadn't thrown up anymore and otherwise was acting okay. And yet he was shuttled through this process where 6 to 7 hours after the initial injury, he finally left the ER after me telling him, yeah, you have a concussion. Unfortunately, this is a really common experience for me. I probably see 2 to 3 patients every week who get sent into the emergency room to be evaluated for concussion. The issue is that concussion is what's called a clinical diagnosis. What that means is we actually make that diagnosis based off of the history, what happened to the patient, and their exam. How they look on exam, what is their medical exam, what is their neurological exam like. We don't actually do any formal testing for concussion. And when I say formal testing, I mean blood work or CAT scans, MRI. We don't need to do any of that in the emergency room. There's nothing on that image that actually helps me make that diagnosis. Instead, I just end up asking the same question that team trainer and the urgent care provider ask, and they say, thumbs up, you have a concussion, here's how you can manage it at home. Ultimately, what that means is if anyone sees a medical provider outside the emergency room and gets diagnosed with a concussion, and there isn't a specific concern about skull fracture, brain bleed, neck trauma, or any other significant trauma, it doesn't require an emergency room visit and could probably save these patients hours of their time, not to mention hundreds of dollars if you skip the ER visit for a known concussion with no other concerns. And lastly, speaking of wasting hundreds of dollars for no benefit, I had this really frustrating case 2 days ago where this 22-year-old young woman came into the emergency room because she had a Q-tip stuck in her ear. It was late at night, and right before she came into the ER, she was cleaning her ear with a Q-tip, which technically you're not supposed to do, and half of it actually snapped off within the ear canal. She was having a little discomfort, but thankfully the discomfort was bearable and there wasn't any bleeding. But it was too late at night for her to call her primary doctor, or frankly, the urgent care center near her was closed. So without other options, she came into the emergency room. Did she think she was having an emergency? No. But did she have a medical problem that she wanted to get evaluated because she didn't want to go to sleep with plastic stuck in her ear? Yes. What was really frustrating about that visit for her, and frankly for all of us, is how broken the US healthcare system is when it comes to emergency care. Medical billing in the US is incredibly complex, but one of the things that's good to know is when you check into an emergency room, when you're evaluated by a nurse, have your vital signs taken, have your triage story, basically what you tell the nurse, the reason why you're coming into the ER, put into the electronic health record, that already generates something called a facility bill. This hospital charge is essentially what the hospital bills you for showing up in that initial evaluation in the emergency room. And it's separate from any medical provider charges, meaning that even if you don't see a doctor, the hospital will still generate this bill. Now, of course, unlike everything else in the world where you know what something's going to cost before you buy it, the moment this young woman walked into the emergency room and was evaluated triaged, had vital signs and a history put in the system, her health insurance generated a copay for over $800 just for being evaluated in the emergency room before me or any other medical provider had even seen her. At that point, this poor young woman was in tears because she didn't want to spend $800 to have someone pull a Q-tip out of her ear. She would have waited till the morning or called her primary doctor or gone to an urgent care that was a little farther away. But no one tells you ahead of time when you come into an emergency room how much it's going to cost. Believe me, as an emergency doctor, I hate that too. I don't want people coming into the emergency room and getting slammed with $100 bills because they have a medical problem and don't know what to do about it. For some reason, we are the only developed country in the world who hasn't figured this out yet, and it's infuriating. Unfortunately, at this point, this young woman was stuck between a rock and a hard place. The moment she had been evaluated by that nurse and her vital signs had been put in, that facility charge had already been generated. Now she had this tough choice. Does she just leave with this Q-tip in her ear and still have to pay the hundreds of dollars for that initial evaluation? Or does she stay and potentially generate an additional bill from the medical providers who see her on top of the hospital bill just to have this Q-tip plucked out of her ear? It's a broken system, and believe me, even as someone who participates in the system, I really wish it would change. Ultimately, the young woman just decided to leave because she figured that it would be better to not double the bill she was already going to owe and just be seen by her primary doctor in the morning to have it taken out. But gosh, what a shame. And frankly, that shouldn't happen in one of the richest countries in the world. There you go, some of my stories from this week in the emergency room. Tons of flu, still some rhinovirus, a smattering of COVID, lots of parents not giving their kids meds before coming into the ER, lots of confusion about concussion diagnosis, and this poor young woman who got trapped with an $800 bill just to be seen for a Q-tip in her ear that she didn't even get taken out. I guess that's US healthcare for you. If you like this video, thanks for watching. Please like, subscribe, and I'll see you next week if people found this helpful for volume 2 of This Week in the ER.